All right, welcome back everybody to the deep dive. We're diving into a topic today that's pretty fundamental for anyone working in cardiac care, and that's cardiac diagnostics for nurses.
Yeah, absolutely. It can feel like things are constantly changing and evolving in this field.
Definitely.
And, there are so many incredible advancements in cardiovascular medicine, but it can be really hard to keep up with it all.
Yeah, it's like trying to drink from a fire hose sometimes, right?
Oh, absolutely.
So we're going to really try to break it down today and make sense of all those key tools we use every day to figure out what's actually going on with our patients' hearts.
Yeah, exactly. Because it's not just about knowing the names of the tests, right?
Right.
It's about really understanding what information they give us, how to interpret those results, in the real world,
Yeah.
and ultimately how that knowledge translates into better patient care.
Right, because at the end of the day, it's all about taking care of those patients.
Yeah.
So for this deep dive, we've been poring over tons of information, specifically excerpts from a really comprehensive resource
Oh, yeah.
focused on cardiac diagnostics, pharmacology, and interventions for nurses.
Nice.
And that's really where you come in, dear listener,
Yeah.
because our mission today is to take all of that, all those details, and extract the most important knowledge about these cardiac diagnostic tests and make it stick.
Right. Cut through the noise.
Yeah. Cut through all the complex.
Yeah, the good stuff.
Yeah, exactly. The good stuff. And maybe, just maybe, we'll throw in a few surprising things you might not have known before.
Always fun.
Right. And really, our goal is to arm you with a much deeper understanding of cardiac diagnostics that you can immediately put into practice at the bedside.
That's the goal.
So you can walk away from this feeling confident and ready to tackle anything.
Ready to go.
All right. So to kick things off, we're going to start by building your diagnostic toolkit.
Okay. Love it.
And that means exploring those various cardiac diagnostic tests and imaging modalities.
Mm.
Everything from those electrical whispers of the heart
Yes.
to those incredibly detailed pictures that show us its structure and function.
I mean, it's pretty amazing how far we've come with all this, right?
Oh, it's amazing.
Yeah.
It really is remarkable, all the different ways we can sort of peek into the heart these days, both those non-invasive tests
Yeah,
and the procedures that give us a super detailed look inside.
totally.
And like you said, the goal is to get to an accurate and timely diagnosis
Yes.
for a whole spectrum of cardiac conditions.
Absolutely. And, the nurse's role in this whole process, from start to finish,
Yeah,
super important.
it is.
You're the one, a lot of times, who's that first point of contact.
Right.
You're preparing the patient, you're explaining what's going to happen, which honestly can go a long way in easing anxiety.
Oh, absolutely. They're coming in, scared,
Yeah.
nervous, not knowing what to expect.
Right. And you're that reassuring presence. And
Exactly.
you're also monitoring them during and after the tests. And maybe the most important part is you're connecting the dots between those test results
Yes.
and what you're actually seeing clinically with your patient.
It's all about that clinical correlation.
Yeah, absolutely.
Okay, so let's start building this toolkit then.
Okay, let's do it.
And let's start with the electrocardiogram,
The good old ECG.
the ECG, or some people call it the EKG.
All right, both are fine.
Yep, either way. And, it's been around forever.
It has, but it's still going strong.
Yeah, but still such a foundational piece of equipment in cardiac diagnostics, right?
Yeah.
I always think of it as kind of like
Yeah,
learning the heart's first language.
you got it. I love that analogy.
Right, it's how we first learn to read what the heart's telling us.
Absolutely. The principle behind it is actually pretty simple.
Okay,
It's basically reading the electrical story of each heartbeat.
I like that.
It's a non-invasive test, so nothing goes inside the body,
Right.
and it records the heart's electrical activity as those cells, switch on and off.
Depolarize and repolarize.
Exactly. You're a pro. Oh, stop it. But those little stickers, the electrodes we put on the skin?
Yeah.
They pick up those tiny electrical currents, which are then amplified and displayed as a graph.
Like those squiggly lines we're all used to seeing.
Exactly. And you're right. Despite all the fancy imaging we have these days, the ECG is still super important.
Yeah, I feel like we still use it all the time.
All the time. And it's because it's accessible. We can do it right there at the bedside in minutes. It's fast.
Yeah.
And it gives us so much valuable information.
It really does. I mean, it can tell us so much.
It's often our first clue in figuring out what's going on with the heart.
And when we say we'd order an ECG, it's not just for those dramatic chest clutching moments, right?
No, not at all. It's not just for the movies.
Right. There's a whole range of
A
reasons.
huge range.
Okay, so walk us through some of those.
So acute chest pain, that's definitely a classic reason, right? But we also use it for patients who are having palpitations, that fluttering or racing feeling in their chest.
Oh, yeah.
Or syncope, which is just a fancy word for fainting.
Okay.
And dyspnea, or shortness of breath.
Okay.
And, it's essential for detecting and monitoring acute coronary syndromes.
Okay, so that whole spectrum from unstable angina to an actual MI.
Exactly. And it's super helpful for diagnosing and monitoring arrhythmias, too.
Yeah.
And it can even show us the impact of electrolyte imbalances, like dangerously high or low potassium, which we see sometimes.
Okay.
And it can show us the effects of certain medications, like digoxin toxicity.
Right.
And we use it to make sure that pacemakers and those implantable defibrillators, or ICDs, are working the way they should be.
Okay.
So it's pretty versatile.
It really is. And, sometimes we even use it for screening or during exercise stress testing.
Right, to see how the heart handles that extra workload.
Now, I remember hearing something about a specific time frame for getting an ECG on someone you suspect is having a heart attack.
Yeah,
Like, isn't there a 10-minute window that's super critical?
Yes, you are exactly right.
Why is that so important?
So for anyone with suspected acute coronary syndrome, getting that 12-lead ECG done and interpreted within 10 minutes of them getting to the ED,
Okay.
or even sooner, like when the paramedics arrive.
Right at the scene.
Exactly. That's not just a guideline, it's like a golden rule.
Okay.
Because in that situation, time is muscle, literally.
Yeah.
The faster we can diagnose them,
Yeah.
the faster we can make decisions about treatment, like getting them to the cath lab
Right.
to open up that blocked artery, which means we can save more heart muscle.
Yeah, that makes sense.
And that can really improve their chances of survival.
Every minute counts.
Absolutely.
Okay, so we know why the ECD is important. We know when we need to use it.
Yeah.
Now let's talk about the actual procedure.
Okay.
Because it seems straightforward.
Right.
But there are some key steps, especially with lead placement.
Oh, absolutely. Lead placement is crucial.
It's like following a very specific roadmap, right?
Exactly. Like you're navigating on the patient's body.
Okay, so tell us about that roadmap.
All right. So a standard 12-lead ECG uses 10 electrodes.
Okay.
4 of them are limb leads, and they go on the arms and legs.
Okay.
And the other 6 are called precordial leads, and those go on the chest.
Okay.
And they're labeled V1 through V6.
Right. And those different leads, they're giving us different views, right?
Exactly. So the limb leads, those are giving us a view of the heart's electrical activity in the vertical plane.
Okay.
And the precordial leads, those are looking at it in the horizontal plane.
So it's like taking pictures from different angles.
Yeah, exactly. We get a more complete picture that way.
Like a 3D view.
Yes. A 3D electrical view of the heart.
Okay, I like that.
So cool.
Right. And could you just give us a really quick rundown of where all those leads go?
Oh, yeah, definitely.
Because it's easy to get it mixed up if you don't do it all the time.
It is for sure.
It's one of those skills where precision really matters.
Precision is key.
Yeah.
Okay, so for the limb leads, RA, that's right arm, it goes on the inner wrist. LA is left arm, also on the inner wrist.
Inner wrist.
RL is right leg, and that one usually goes on the inner ankle.
Okay.
And that acts as our ground.
All right.
And then LL is left leg, also on the inner ankle.
All right. So arms and legs, we've got that down.
Got it.
Now those chest leads, those are the ones I always mix up.
Yeah, those can be a little tricky.
Where do all those V's go?
Okay, so V1, that one goes in the 4th intercostal space, right next to the sternum on the right side.
Okay.
V2 is basically right across from it, also in the 4th intercostal space, but on the left side of the sternum.
Yeah.
V3, that one's kind of in between V2 and V4.
All right.
V4 is placed in the 5th intercostal space, right at that midclavicular line.
So imagine a line going straight down from the middle of the collarbone.
You got it. V5 goes at the anterior axillary line, same level as V4, so think about a line down from the front of the armpit.
Okay.
And then lastly, V6 is placed at the mid-axillary line, same level as V4 and V5, so straight down from the middle of the armpit.
Okay, so each of those positions, it's giving us a different electrical snapshot of the heart, right?
Exactly. They each look at a different section.
And it's so important to get them right.
It is, because, if you put those leads in the wrong spot,
Yeah.
it can actually make the ECG look like there's a problem when there isn't one, or it can hide a real problem.
It's like looking at a distorted map, right?
Totally. You wouldn't want to use a wrong map to get somewhere.
No, you'd get totally lost.
Exactly.
So, for example, a misplaced lead could create changes on the ECG that look like a heart attack when there isn't one, or it could mask the signs of a real heart attack.
Exactly. And that's obviously a huge deal.
That's a really big deal.
Yeah. So double checking your lead placement,
Yeah,
that's like a non-negotiable step.
definitely. And, we all learned this in nursing school, but it's good to be reminded.
Absolutely. It's a good refresher.
So let's go over some of those key nursing considerations when we're actually getting an ECG on a patient.
Okay. Good idea.
what are the things we need to think about to get a good, clean tracing?
All right, so before you even start, pre-procedure.
Yeah.
The first thing, always, is explaining the test to the patient.
Right. Tell them what's happening.
Yeah, and keep it simple. Reassure them that it's not going to hurt, it's not invasive.
And privacy is important, too.
Oh, absolutely. Nobody wants to feel like they're on display.
So make sure they're comfortable, covered up.
Yes, and then you want to make sure they're lying as still as possible.
Okay.
Because even small movements, like if they tense up their muscles or shiver, it can create artifact.
Artifact.
Which is basically those fuzzy lines on the tracing that make it hard to read.
Okay, so we want a nice, clean tracing.
Yes. And skin prep is super important for good contact with those electrodes.
So tell us about skin prep.
All right, so usually you'll clean the skin with an alcohol wipe.
Okay.
Unless there's a reason not to remove any oils or debris.
Okay.
And you might need to gently rub the area with a gauze pad to remove any dead skin.
And what about hair? Sometimes there's a lot of chest hair.
Yeah, so if there's a lot of hair, you might need to clip it.
Okay.
Just to make sure those electrodes are making good contact.
Okay.
But try not to shave the area if you can avoid it.
Okay.
Because shaving can actually cause little cuts or irritation, and that can interfere with the tracing.
Good point.
And always check those electrode expiration dates.
Oh, yeah, good reminder.
And make sure the gel is still moist.
Okay.
Because a dried out electrode, that's not going to conduct well.
Yeah, it's not going to pick up that electrical activity.
Right. And then, of course, you got to place all 10 electrodes correctly. We went through all that.
We did.
And make sure you get the patient's information into the ECG machine.
Right. Name, date of birth, all that good stuff.
Exactly. And then during the procedure, just remind the patient to stay still and breathe normally.
Okay.
And keep an eye on that tracing on the screen.
Okay.
If you see artifact, try to figure out what's causing it. Maybe the patient shifted, or there's some muscle tremor, or even something like interference from an IV pump.
Okay.
And if the quality is bad, don't be afraid to redo the recording.
Better to get it right.
Absolutely. And then after the procedure, remove the electrodes gently, clean off any gel,
Okay.
check the skin for any redness or irritation.
And then label that tracing clearly.
Yes, super important.
Okay.
Full name, date of birth, date and time of the ECG, and your initials.
Document everything.
Yes. Document the procedure, how the patient tolerated it.
Okay.
And this is the most important part, okay? If you see anything critical on that tracing, like ST elevation, which could mean a heart attack, or any dangerous arrhythmias,
Yeah.
you got to tell the doctor or the MP immediately.
Immediately. Don't wait.
Time is muscle, we know that.
Exactly.
Okay, so we've got our ECG tracing, we've placed the leads correctly, we've got a good, clean tracing.
Great.
Now we've got to interpret it.
Right. The fun part.
The fun part, the part that can be a little daunting for some. I know, it can seem overwhelming at first.
Yeah, it's like learning a whole new language.
It is, but it's a language that can save lives.
That's true.
So we start with understanding the ECG paper itself.
Okay, those little squares and the bigger ones?
Yes. Those squares represent specific units of measurement.
Of time and voltage.
Exactly. So horizontally, each small box represents 0.04 seconds.
Okay.
And a big box, which is 5 small boxes, is 0.20 seconds.
Okay.
Vertically, each small box is 0.1 millivolts of electrical activity.
Okay.
And a big box is 0.5 millivolts.
This is like a super precise graph.
It is. It has to be precise so we can compare ECGs from different times and different machines.
Okay, that makes sense.
So it's all standardized.
And you mentioned a systematic approach to interpretation.
Yes. There's a method to the madness.
Because where do we even begin with all those squiggly lines?
Right. It can be a lot.
So what's the first step?
So usually we start by figuring out the heart rate.
Okay, is it too fast, too slow, or just right?
Exactly. Then we look at the rhythm. Is it regular or is it irregular?
Okay.
After that, we might check the cardiac axis, though that's often analyzed in more detail by the doctor.
Okay.
But it's good to have a basic understanding.
Yeah, absolutely.
And then we measure the intervals, so the PR interval, the QRS duration, and the QT interval.
Okay.
And then we examine the P wave, how it looks, its relationship to the QRS complex.
Okay.
And then we analyze the QRS complex itself, its width, if there are any abnormal Q waves,
Wow.
and how those R waves progress across the chest leads.
And finally, we look at the ST segment and the T wave for any significant deviations.
Yes. And then, and this is super important, we put all of those pieces together
Okay.
to come up with an overall interpretation, and we always keep the patient's clinical presentation in mind.
Right, it's like solving a puzzle.
Exactly.
So let's break down some of those components, starting with heart rate.
Okay, heart rate.
How do we figure that out just by looking at those lines on the paper.
All right, so if the rhythm is regular, there's a quick trick.
Okay. You count the number of large squares between the peak of one R wave and the peak of the next R wave.
Okay.
So if there's one large square, the rate is about 300 beats per minute.
Okay.
2 large squares, it's about 150.
Okay.
3 large squares, about 100, and so on.
So it's kind of a shortcut?
It is.
Yeah.
But you can also be more precise if you need to.
Okay.
You count the number of small squares between 2 R waves and divide 1500 by that number.
Okay, that's more precise.
It is, but if the rhythm is irregular, like in atrial fibrillation, it's a little different.
Okay, what do we do then?
So then we look at a 6-second strip on the ECG paper,
Huh.
which is 30 large boxes,
Okay.
and we count the number of R waves in that strip and multiply that number by 10.
And that gives us the heart rate.
Exactly. And remember, a normal resting heart rate for an adult is usually between 60 and 100 beats per minute.
Okay.
Anything slower than 60 is bradycardia, and anything faster than 100 is tachycardia.
And we can calculate the atrial rate the same way, right? Yes. But instead of looking at the R waves, you look at the P waves.
Okay.
And in a normal sinus rhythm, those rates should match up.
Okay, so each P wave should lead to a QRS complex.
Exactly.
All right, what about the rhythm then?
Okay, so rhythm is all about how regular the heartbeat is.
Okay, is it steady or is it all over the place?
Yeah, basically. We look at the distance between each QRS complex. That's called the RR interval.
Okay.
If those intervals are all the same, it's a regular rhythm.
Like in normal sinus rhythm.
Exactly. Now, if it's irregular, there are a few different types.
Okay.
So regularly irregular means there's a pattern to the irregularity.
Okay, so it's not completely random.
No, it's not.
All right,
Like in some types of second-degree AV block.
we'll get to those later.
Yes, we will.
Yeah.
Or even in something like ventricular trigeminy,
Okay.
where every third beat is a PVC.
Okay.
Then there's irregularly irregular,
Okay.
which is basically chaos.
It sounds like atrial fibrillation.
That's the classic example. No discernible pattern at all.
All right, and then we have the P wave,
Ah, the P wave.
that little bump before the QRS complex.
Small but mighty.
What does it tell us?
Okay, so the P wave shows us the electrical activity as the atria, the top chambers of the heart, depolarize.
Okay.
And normally, there should be a P wave before every QRS complex,
Okay.
which means that the electrical signal started in the SA node, the heart's natural pacemaker.
Okay.
Now, if there's no P wave, or if it looks weird,
Okay.
it might mean the signal is coming from somewhere else, like the AV junction or even the ventricles.
Okay.
And a normal P wave should be smooth, rounded, and look the same across the tracing.
Okay.
If the P waves have different shapes, it could mean there's ectopic atrial activity going on.
So different spots in the atria are trying to start the heartbeat.
Exactly. It's like
Huh.
they're competing.
And what about peaked P waves?
So peaked P waves, sometimes we call those P pulmonale,
Okay.
and they can suggest that the right atrium is enlarged,
Okay.
which can happen with lung problems. Notched or wide P waves, those are called P mitral,
Right.
and those might mean the left atrium is enlarged, which can happen with mitral valve issues.
Okay.
And normally, the P wave should be upright in leads I to an AVF,
Okay.
and inverted in AVR. That's the normal direction.
Got it.
And of course, the relationship between the P wave and the QRS is super important.
Okay. 1 to 1. Right.
Ideally, yes, one P wave for every QRS.
Okay.
If there are more P waves than QRS complexes, it could mean there's some kind of AV block.
So some of those signals from the atria aren't making it through to the ventricles.
Exactly. And in complete heart block or third-degree AV block, or even in ventricular tachycardia, you might see AV dissociation.
Okay. So what does that look like?
So it basically means the atria and the ventricles are doing their own thing. They're beating independently, no relationship between the P waves and the QRS complexes.
Like 2 separate rhythms happening at the same time.
Exact.
So much information in that little P wave.
Right. Don't underestimate it.
Okay. What about the PR interval then?
Okay, so the PR interval, that tells us how long it takes for that electrical signal to go from the atria
Okay.
through the AV node,
The AV node.
which is like the gatekeeper of the heart's electrical system,
Right.
and down to the ventricles.
Okay.
So we measure it from the start of the P wave to the very beginning of the QRS complex.
All right.
Normal duration is between a 0.12 and 0.20 seconds,
Right.
which is about 3 to 5 small boxes on that ECG paper.
Okay.
And it should be pretty consistent from beat to beat.
All right. And what if it's prolonged?
So if it's longer than 0.20 seconds, that's a first-degree AV block.
Okay, what does that mean?
So the signal is getting through to the ventricles, but it's slowed down a bit.
Okay.
Now, in second-degree AV block, there are two types.
Okay.
Mobitz type I, also called Venka-Bach.
Right.
You see this pattern where the PR interval gets longer and longer with each beat
Okay.
until a QRS complex just drops out and
Yeah.
then the cycle starts over. It's like the AV node is getting tired and needs a break.
I like that.
Right. Then there's Mobitz type 2,
Okay.
where the PR interval stays the same, but then a QRS complex just disappears.
Okay.
No warning.
And that one's more serious.
Often, yes, it can be.
All right.
And then if the PR interval is all over the place with no relationship between the P waves and the QRS complexes, that's a third-degree AV block, or complete heart block.
Okay, what does that mean?
That means the atria and ventricles are totally independent. They each have their own pacemaker.
Wow.
Yeah, it's like they're not even talking to each other.
Okay.
And then a short PR interval, less than 0.12 seconds. Sometimes you'll see a delta wave with that.
Okay.
That can suggest Wolff-Parkinson-White syndrome,
Okay.
which means there's an extra pathway between the atria and ventricles.
So the signal kind of bypasses the normal route.
Exactly. It takes a shortcut.
All right, now let's talk about the QRS complex, the big one.
Yeah, the main event.
This is the ventricles depolarizing.
Yeah.
Right.
Yes. The ventricles are the main pumping chambers, so this is a big deal.
Okay, so what are we looking for with the QRS?
So the duration or width of the QRS complex is super important.
Okay.
We measure it from the beginning of the Q or the R wave, if there's no Q, to the end of the S wave.
Right.
That's also called the J point.
The J point.
Okay, and normally it should be pretty narrow, usually between 0.08 and 0.10 seconds.
Okay.
Sometimes up to 0.12 seconds can be normal. It depends on the person.
Go ahead.
So a narrow QRS complex, less than 0.12 seconds, usually means the signal started above the ventricles.
So in the atria or the AV junction.
Right, and it was conducted normally through the ventricles.
Okay.
Now, if it's wide, 0.12 seconds or more, it could mean a couple of things.
Okay.
It could mean the signal started in the ventricles themselves.
Like in ventricular tachycardia.
Yes. Or it could mean the signal started above the ventricles, but it's being conducted slowly through them,
Okay.
like in a bundle branch block.
So it's like a traffic jam in the heart's electrical system.
Exactly. The signal is getting slowed down.
Okay, so that's the width.
Yes.
What else are we looking at with the QRS?
We also look for pathological Q waves.
Okay, what are those?
Those can be a sign of a previous MI, a heart attack.
Okay.
They're usually wider than 0.04 seconds, or they're deeper than 1/3 the height of the R wave,
Okay.
or deeper than 1 millimeter in certain leads.
All right, and we also assess R wave progression.
Yes. That's looking at how the height of the R wave changes across the precordial leads, V1 through V6.
Okay.
Normally, it should get taller as you go from V1 to V5.
Okay.
If it doesn't, it could mean there's a problem with the anterior wall of the heart.
Okay, like a previous MI in that area.
Exactly. And finally, we look for signs of ventricular hypertrophy.
So that's when the muscle of the ventricles gets thicker.
Yes,
Rough.
often because of high blood pressure or other conditions.
Okay.
And one example of that is the Sokolow-Lyon index, which can suggest left ventricular hypertrophy.
All right, so much to look at with the QRS complex.